All right, today we're diving into one of the highest stakes topics in all of critical care, ECMO. And look, my goal here isn't just to dump a bunch of facts on you for the boards. It's to give you a mental framework that's absolutely rock solid. So when you're faced with that crashing patient at 3 in the morning or a tough question in the exam room, these concepts are going to be baked into your brain, just second nature. Let's get into it. So here's how we're going to build your expertise step by step. First, we'll get our hands dirty and basically deconstruct the machine itself. Then we're going to nail down that one core choice that changes everything, VV versus VA. After that, we'll talk about when to pull the trigger, how to actually get the cannulas in, and finally, and maybe most importantly, how to see the dangers coming and shut them down before they become a disaster. This is your roadmap. Okay, section 1, the machine. You know, for a lot of us, that ECMO circuit can feel like this terrifying black box of tubes and alarms. Our goal right now is to rip it open and see the engine inside. By the end of this, you're not going to see anxiety, you're going to see a tool you can actually control, whether you're at the bedside or staring down a board question. Okay, let's nail down the single most important philosophy right from the start. The one sentence that has to guide every single decision you make. ECMO is not a cure, it's a bridge. Look, we're not curing the ARDS, we're not curing the cardiogenic shock. All we're doing is buying time. Time for the lungs to rest, time for a stunned heart to recover, or time to get that patient to a transplant. The second you forget that, you start treating the machine, not the patient. Remember, it's a bridge to somewhere else, not the final destination. Now let's talk about the engine of this thing, the pump. Your textbooks might mention 2 types, but for your exam, one's ancient history, the other is the only right answer. Think about those old roller pumps. They were just brutal. They had no brains, they were not afterload dependent, which means if there was a kink in the line downstream, they'd just keep pushing and pushing until boom, the circuit ruptures. Total disaster. But the modern centrifugal pump, it's way smarter. Why? Because it's afterload dependent. Think of it this way. If it hits a roadblock, it eases off the gas. That simple safety feature, plus the fact that it doesn't chew up red blood cells, is why it's the only right answer. All right, next up, the artificial lung, the oxygenator. And honestly, managing it is simpler than it looks. You have 2 main things to watch. First thing, sweep gas. That's your CO2 knob. Think of it exactly like the respiratory rate on a ventilator. You crank up the sweep gas, you sweep out more CO2. That's it. So how do you know if this artificial lung is starting to fail? You're going to watch the delta P, the pressure gradient across it. Imagine it's a coffee filter. As it gets clogged with grounds, or in this case, tiny clots, you have to push harder to get liquid through. That rising pressure, that's the oxygenator telling you it's dying and needs to be changed out. Okay, so let's boil this whole thing down. As the surgeon, you've basically got a control panel with 3 main knobs. That's really it. First knob, flow. You turn up the pump RPMs, you get more flow, you get more oxygen delivery. That's your cardiac output right there. Second knob, sweep gas. We just covered it. That's your ventilation. You turn it up to blow off more CO2. And your third knob is the blender, your FiO₂. This just makes sure the blood going back to the patient is maxed out with oxygen. Cardiac output, ventilation, oxygenation. Master these 3 knobs and you are in total control. You gotta remember, the body sees this whole circuit as one giant foreign invader, and it immediately tries to clot it off, so you have to anticoagulate. It's not an option. For years, everybody used the ACT, but the problem is it's kind of like using a sledgehammer for a delicate job. It's just not precise, it's affected by everything. So what's the modern board standard answer? It's the anti-factor XA level. It's way more reliable, and it's for sure the answer they're looking for on your exam. All right, let's lock all this in with a simple mnemonic, POEM. P is for the pump, the smart, safe, centrifugal one. O is for the oxygenator, that's our artificial lung. E is for the extracorporeal circuit itself, all the tubing that connects everything. And M is for monitoring, your flows, your pressures, and especially that anti-EXA. POEM. Remember that, and you've got the machine down cold. Okay, time for a classic board trap. Let's see if you're paying attention. You got a patient on VVE ECMO for bad ARDS. The blood gas comes back and their PaCO2 is climbing. What's the very first thing you do? So, the rookie mistake, the thing your gut might tell you to do, is to run over to the vent and crank up the rate. Big mistake. Think about it. Why are they on ECMO? Because their lungs are a complete disaster. The whole point of VV ECMO is to let those lungs rest, put them on vacation. So if the CO2 is up, the last thing you want to do is beat up the lungs even more. You go to the machine that's actually doing the ventilating now, the ECMO circuit, and you turn up that CO2 knob, the sweep gas. This is a core principle they will absolutely test you on. Okay, moving on to section 2. And this is the big one, the the fork in the road. Veno-venous versus veno-arterial. Get this wrong, and it's a catastrophe. I want you to forget all the complexity for just a second. This whole decision comes down to one simple question. Is the heart working? If the heart's pumping fine, but the lungs are shot and you just need oxygenation, that's VV ECMO, no circulatory support. But if the pump is broken, if the heart has failed, you absolutely have to support the circulation. That means you have no choice. It has to be VA ECMO. It is that simple. So here it is, your whole decision tree, your safety algorithm. And it all starts with this one question. Is the patient in cardiogenic shock? Yes or no? If the answer is yes, they're hypotensive, maxed out on pressors, kidneys are failing, the heart's done, the decision is already made for you. You need circulatory support. You choose VA ECMO. End of story. Okay, but what if the answer is no? Their pressure's holding up, but their sats are in the tank. They're profoundly hypoxic. So your next question is, do they have killer ARDS? And the classic number for that is a P to F ratio less than 80. And if that's a yes, now you've defined the problem. It's just the lungs. The heart's chugging along, but the lungs have quit. So you choose VV-EMO. It will handle the gas exchange, letting those lungs rest. See? It's a really clean, logical path. Okay, so we know which one to choose. Now, let's get super specific. Because for the boards, they want to see you know the exact numbers, the evidence for when you actually pull that trigger. For VV ECMO, this is it. This is the magic number you have to burn into your brain, a FiO₂ to FiO₂ ratio less than 80. This isn't just some random number. It comes straight out of the huge EOLIA trial. It's what defines severe ARDS that needs ECMO. But hold on, ECMO is a huge deal. It is the absolute last resort. And on your exam, you have to prove you tried everything else first. That means you've already done the full ARDS NAP playbook, you've got them on low tidal volumes, you've cranked up the PEEP, you've had them proned for more than 16 hours, and you've even paralyzed them. Only after they failed all of that, then and only then can you justify ECMO. Okay, for your boards, you need to know two landmark trials. First, CSAR, back in '09. The big takeaway, just sending a patient to an expert ECMO center saved lives. Bottom line, this is not a solo sport. And then EOLIA, more recently, gave us that magic number, the PSAF ratio less than 80. Those two trials are the foundation of modern VV ECMO. All right, for VA ECMO indications, you're going to use the mnemonic CAMP, C-A-M-P-R. C is for cardiogenic shock. That's your classic post-heart attack patient crashing. A for arrest, we're talking ECPR, which is a huge deal now. M for myocarditis, like that young, healthy person who gets a virus and their heart just tanks. P for a massive pulmonary embolism where the RV is just pancaked. And R for refusal to wean from cardiac bypass. CAMP-R covers your bases. Just as important as knowing when to go is knowing when to stop. The absolute no's are pretty clear. A totally wiped out brain. Uncontrollable bleeding. And here's a huge one for VA ECMO, aortic dissection. Think about it. That retrograde flow is like a fire hose aimed right at the tear. It'll just rip the aorta apart. It's a 100% no-go. The relative ones are more of a judgment call. All right, decisions made. Time to get to work. Let's talk about the surgeon's part, cannulation. This is our world. The focus is on anatomy, the setup, and how to prevent disaster. So for VV ECMO, you've basically got two flavors. The old school way is two sites. You drain from the femoral vein and return oxygenated blood up in the IJ. The slicker, more modern way is a single dual-lumen cannula, like the Avalon in the IJ. And the huge win here? The patient can actually get up and move. We can even get them walking sometimes. It's a game changer. Now for VA ECMO, the bread and butter is peripheral, fem-fem, draining from the femoral vein, returning to the femoral artery. In a crash situation, ECPR, this is the fastest way to get them on support. The other option is central, right through the chest. Yeah, it's a bigger operation, but it completely avoids the gnarly leg problems we're about to hit. Okay, this leads us to maybe the most important high-yield procedural question in all of ECMO. You've just put that big arterial cannula in the groin for VA support. What is the absolute mandatory next move to save that leg? The answer is non-negotiable. If you forget this, the patient loses their leg. You must place a distal perfusion cannula, or a DPC. I mean, think about it. You've just shoved a giant hose into the femoral artery. It's blocking all the flow downstream. Without a DPC, you are literally causing an amputation. It's not a nice to have. It's the standard of care. And the technique is actually pretty slick. You just put a small sheath in, antegrade, pointing down toward the foot, into the SFA. You connect that little sheath to the arterial side of the circuit, and boom, you've created this little bypass that keeps blood flowing to the lower leg, saving it from ischemia. It's an absolute must-know.
Okay, cannulas are in, patient is on support. Now for the scary part, the final high-stakes section, spotting and dealing with the disasters that are always waiting to happen.
So let's run through the big dangers. In the circuit, you'll sometimes see the lines start to shake like crazy. We call that chatter. That's your drainage cannula sucking the wall of the vena cava dry. It means you're hypovolemic. The fix is simple. Give them fluid. And for the patient, it's all about bleeding. The most common problem is a bleed somewhere, but the one that will kill them, the most lethal, is a head bleed. Okay, here's a weird one that's specific to VV ECMO: recirculation. Imagine your fresh, oxygenated red blood is being returned to the patient, but the drainage cannula is so close it just sucks that red blood right back into the circuit before it ever gets to the body. The circuit is spinning its wheels, doing a ton of work for zero benefit. And the fix is dead simple. It's a plumbing problem. You just have to reposition the cannulas to get more space between them.
Now this is a terrifying complication of VA ECMO. All that retrograde flow from the circuit just slams the door shut on the LV. The ventricle can't pump against that pressure, so it just swells up like a balloon, flooding the lungs with edema. The only way to fix it is to decompress that LV, fast, usually with something like an Impella or a balloon pump. You have to vent it.
Okay, pay attention. This is the single most elegant and dangerous board question they can throw at you. You run rounds, your VA ECMO patient's femoral art line looks beautiful, SAT is 99%, but then you look at their right-hand pulse ox, and it's 82%. What is going on? What you're seeing is Harlequin syndrome. The patient's own heart is starting to wake up a bit, but it's pumping blue blood from those sick lungs, and that blue blood is going to the brain and the right arm. At the same time, the ECMO circuit is sending beautiful red blood to the lower half of the body. Cranking up the ECMO flow does nothing for the brain. The only way to fix this is to oxygenate the blood that's actually getting to the brain. And that means you have to go back to the ventilator and crank up the FiO₂. Okay, one last mnemonic to lock in these VAA disasters: LHRC. L is for limb ischemia. You need a DPC. H for Harlequin syndrome. You need more ventilator FiO₂. R for recirculation. Reposition those cannulas. And C for cardiac distension. You gotta vent that LV. LHRC. Burn it in. It could save a life. And that brings us full circle, right back to where we started. You have to remember the core philosophy. It's an amazing piece of technology, but ECMO doesn't actually cure a single thing. It's a bridge. It just buys us time for the body to heal itself. And I'll leave you with one last big picture thought. We literally have the power now to temporarily replace the heart and lungs. And with that power comes a huge question. As surgeons, how do we define the limits? When do we know we've reached the point of no return?